people will be coming with a wide variety of experiences with Parkinson's. And I want to speak directly if you have been diagnosed recently and you're saying, wait a minute, she's going to talk about late stages. I don't want to hear about that. I hope, if nothing else, that you leave this talk with hope. So how are we going to talk about late stages of Parkinson's and hope? Because there absolutely must be. And I hope by the end of this, I convince you of that. So, okay, I may move around a little bit so that I don't have this shining at me. So we're going to talk about a few things. Dr. Alskog did a beautiful job, and I will tell you that I am in the generation that came after the toxicity. So I am not one of those people who was trained to believe levodopa is toxic. I also agree that it is both our safest and our most effective drug, which I challenge you, come up with another condition where that's true, okay? But I was trained during fellowship, and I thought, I finished my fellowship in 2014, and I get out there and I've, hang my shingle as a Parkinson's neurologist. And I started realizing really quickly that I had a lot of experience in those couple of years seeing people early in Parkinson's. But I didn't see people later on. And that made me think, well, maybe this is just what Parkinson's is just, these first few stages. And so we're going to talk about that. And then we're going to talk about how we make a difference and what making a difference for people with later stages can tell us right now for you, regardless of what stage of Parkinson's you're in. We're going to get to that very confusing Lewy body dementia with Lewy bodies. What is this and why does it matter? And then I'm going to tell you a little bit about some of the work that I have the privilege of doing with caregivers and care partners for caregivers and care partners. So that's what we'll go to. So let's start here. So I want to tell you very briefly about a patient of mine, actually. And I don't have a video, but this is a gentleman who was sent to me, and he had not been seen for his Parkinson's for 3 years. And part of the reason was because he couldn't get out of his house without the assistance of 911 and a fireman coming to take him down his stairs. So Medicare and Medicaid, the office, has the definition of homebound, which means that, this is their quote, not mine, because of their medical illness, it is a considerable and taxing effort to get out of the house, right? Which is a considerable and taxing effort to do a lot of things if people have Parkinson's or any number of things. And it requires another person to help. It requires a wheelchair or an assistive device, or it requires special transportation. And so a lot of people might meet that homebound criteria, but they can still go out and see family. They can go to church. They could go to temple. They can go to parties. But my patient truly was homebound. Aside from going to the emergency room, he had not been out of his house in all of those years, right? And so I went to see him, and lo and behold, the Parkinson's was kind of the least of his problems, because we think as movement disorders neurologists, well, we're taking care of the Parkinson's, but someone else is taking care of everything else. And it turns out that there's a lot of what we call neurophobia in medicine, which means other docs who don't take care of a lot of neurologic problems and may have very little training are like, ooh, Parkinson's. All right, you know what? That's really your main issue. And you take care of that. And come see me if you need anything. I'll just be here. And so people fall out of the loop of care. And so this gentleman had not only not seen me or my colleagues, he hadn't seen his primary care doc. He wasn't up to date on his flu shots. He hadn't, had all of the usual screenings. And he'd had heart disease in the past. That was getting out of control. His legs were really swollen. So we might have looked and said, well, Parkinson's causes trouble with walking. His feet were swollen to the size of an elephant, but no one knew. He was starting to have what Dr. Alskog described, these drops in blood pressure. Every time he would stand up, he would get this kind of lightheadedness. And no one knew that. He didn't know that that was a Parkinson's sign. And why would he? Because he wasn't seeing anyone who could help and educate him with that. So we went to the home and found he had been losing weight. He was taking the same medication regimen he'd been taking about 5 years ago with no adjustments. And people, very well-meaning family members kept saying, I read an article, right? Uncle Google told me. And so he kept adding on pills and supplements and vitamins and things, and he was having a really hard time swallowing. And he was losing weight because he was swallowing so many pills that he was filling up and then not eating. And so he was starting to have pressure wounds. All of these things, and just kind of hidden, right? And so I'll get back and I'll tell you what we did with him. But I think he's a really good example. When we think about Parkinson's, I want to convince you that people with more advanced Parkinson's are understudied. They are not represented. What do I mean by advanced Parkinson's? So we have this staging system. People are trying to come up with new and better ones, but for right now, this is what we have. It's called the Hoehn-Yahr staging system. There are 5 stages. And what you'll see is this is defining what these are. Stage 1, people have symptoms on one side of the body, maybe just that little bit of tremor. And often people don't even come to the doctor at stage 1 because maybe it's normal aging, it's not bothering me, I don't really have time, I'm busy, I'm working, I'm doing things. Stage 2 means symptoms are affecting both sides of the body, not necessarily affecting walking or balance. Stage 3 is when we start to see balance be involved. We see more significant symptoms, sort of more moderate symptoms. Then we get to stage 4, which is described as severe mobility, but people can still get up and walk around either on their own, maybe holding on to something as they're sort of cruising, or maybe with the help of a cane or a walker. And stage 5 is designated as someone who is dependent upon a wheelchair or who's bedbound unless they have assistance. So we have 5 stages, right? How many people are in each stage? How long does each one last? These are good questions. You should be asking these questions. You should be putting these down on the index cards. We don't have good answers. We have good answers for stages 1 and 2 and 3. We have no answers for stages 4 and 5. So why? Oh, I'll scoot out of the way. Of course. So I really love, this is now an older figure, but from 2015, Drs. Kalia and Lang made this great diagram. I love the blue triangles, right? And as a movement disorders doc, you saw that we do these little taps, the claps. Everyone practices these on the way in to their neurologist. You don't need to. It's not like flossing before the dentist, okay? We won't know if you practice right then. But what we look for is that slowness of movement, the stiffness, the tremor, the things that you saw in the videos. But what we know impacts people's daily life, right, are the things that can start years before, that REM behavior disorder, people acting out their dreams during sleep, the constipation, the depression, pain, fatigue, cognitive changes, those fluctuations where the meds are going from working to not working, on to off, dyskinesias, and then trouble with swallowing, trouble with balance, falls. And while this doesn't happen to everyone, as time goes on, if something else isn't getting in the way, we start to see more of these symptoms developing. Okay, we know this. Well, then why don't we know sort of the prevalence and how often this happens in people later in these stages? So this is just one example. This is an older study. This is the Priamo study. This is from 2009. And this is one of the studies that helped us say, we call this a movement disorder, but it's so much more than that. There are all of these other non-movement symptoms. So how common are they? And this was just a survey, okay? It didn't require coming back and forth to the office 1,000 times. You didn't have to have blood drawn. You just filled out a survey and said, yes or no, I've got these things. And they surveyed 1,072 people. That's a lot of people with Parkinson's. And in order to capture stages 4 and 5, they had to categorize those folks all together, and they made up a whopping 49 people out of 1,072. That is 4%. So we have 5 stages, and 2 of them are 5% of the people that we know about. That math is wrong. It's just wrong. And I had colleagues tell me, Jori, it's very sweet that you're interested in people with advanced disease, but where are you going to find them? We don't know that they're out there. We just don't have any information about them. And we should not be drawing the conclusion that because we don't have information, They are not out there. They are out there. People are living and thriving with Parkinson's through all of the stages. We need to pay better attention. You need to know that you are not alone and you should not be alone as Parkinson's progresses. So here's what we know is there's a group out of Europe that started working on let's get a better understanding of more advanced Parkinson's, or what they call late-stage Parkinsonism. So there are a couple of different conditions. Dr. Alskog mentioned Lewy body dementia, which we'll get to. There are some cousins of Parkinson's that share some of the features, things like progressive supranuclear palsy, or PSP, multiple system atrophy, or MSA, and cortical basal syndrome. And while we know that the pathology, what we see under the microscope, differs, there are some shared things about these different conditions. And so the group talking about late-stage Parkinsonism said, if we forget the diagnosis that we're calling them, and we look at these different symptoms, do they share things in common? And what they found was, if we say people who functionally require some assistance to walk around, so either a stage 4 or a stage 5, they're dependent on a wheelchair or they're bedbound. These are the things that are very common. A lot of bradykinesia, our fancy word for slowness of movement. Not so much on the stiffness, right? And Dr. Alskog mentioned that, the rigidity, that if we're wiggling you around, giving you a very cheap massage during your visit, right, that rigidity is not the big thing that determines how people do. What is really important later on are that we see freezing of gait, where people stand up and they have start hesitation. They're kind of stuck, right? The clutch isn't moving. And then they may get going, but they may get stuck again as they come to a tight threshold, as they come to a kitchen, a bathroom, right? Turning around, pulling the refrigerator door back and getting stuck and not being able to take those steps. We see issues with falls. We see issues with dysphagia, which is our fancy word for trouble swallowing. Could be with liquids, could be with solids, could be with an excessive number of pills. We see non-motor symptoms, so trouble with sleep. REM behavior disorder was mentioned, the issue of having these really vivid dreams and moving around. Usually the person who has it is not bothered. It's their bed partner who's being whacked and has, set up the fence with the body pillow and everything else. We see trouble falling asleep, though, and trouble staying asleep. We see trouble with waking up to go to the bathroom and not being able to get back to sleep, or waking up super frequently. We also start to see those urinary issues. Urinary tract infections are the bane of our existence with Parkinson's, okay? Because Parkinson's does not change Friday at 4:30 p.m. It does not change. The dopamine cells are not unionized and they do not go on strike Fridays at 4:30 p.m. But when someone calls my office and says, all of a sudden this morning, my walking is worse, or my loved one's hallucinating and they never did before, it is a urinary tract infection until proven otherwise, okay? It is so common. But we see that more as time goes on. And then we start to see changes in thinking and memory, dementia. We see psychosis like hallucinations and delusions. We see depression and changes in the skeleton, so skeletal deformities, things like what we call camptocormia, which is people who are bent over sometimes 90 degrees, and they may be sitting up okay or leaning over to a side. And as they start to walk, they're going like this. There are things we can do. But what's interesting about this conglomeration of symptoms, what we are calling late-stage Parkinsonism, is they found, there we go, sorry. We know that they're really underrepresented in research. It took this European group sort of combining and collaborating to start describing people with these symptoms, not because they weren't out there, just no one was paying attention before. Because what our research shows, if we go to PubMed, that same site where we can look up all kinds of medical information and research studies, there is a lot about early stages of Parkinsonism. Right? This is people who are in our clinics, who I see every day. These are people who are getting enrolled in the latest clinical trials, in the latest trials of exercise. And as time goes on, people are still sticking around in clinical care, but we're getting clinical trials that say, well, you have to be within the first 3 years. You have to do it within the first 5 years of Parkinson's. You have to be able to walk this amount of distance without assistance. And we start to see people be excluded from a lot of research. And then people in stages 4 and 5, this late stage. The only research previously that they've shown up in is retrospective stuff, where we look back and say, why do people with Parkinson's wind up in the hospital? What brings people with Parkinson's to an emergency room? Wait a minute, there's this group of people with Parkinson's in a nursing home. Let's talk about them. That's where they show up. Or what causes people with Parkinson's to pass away? But there's been very little catching people and saying, what is happening while they're there, while they're home, while they're living and thriving with Parkinson's, and what do we do? So where have they been? Where are they? How do we find them? So we have to be a little bit creative to find this information. And I really like this study. This came out during the pandemic. This was done by a group of researchers, and they took data from Medicare recipients. So people living in the US, age 66 for this study and older. And they had information for 7 years. And they followed them out for 7 years. And the question was, what happens? Where do people go? At the end of 7 years, where are they? And it's pretty interesting. So of 35 million people, age 66 and over, after 7 years, 23.7% had passed, had died. 1.2 million, or 3.4%, were in a nursing facility. And you might think, well, that's okay, right? And there are great nursing facilities out there. There are. However, there are very few that know about Parkinson's, that understand that if you take your levodopa at 8, noon, and 4, that means you take your levodopa at 8, noon, and 4, not when it is convenient for them to give it to you and it just sometimes gets in 3 times a day, right? And so what we know actually is that people with Parkinson's who are in nursing facilities in general lose access to seeing a neurologist for most of the time that they're there. In fact, only 37% of people with Parkinson's in a nursing facility saw a neurologist in the year before they passed. And that's shameful. We know that people deserve that care. But what else? Okay, so if people are alive and they're not in a nursing facility, what else? I described our definition of homebound to you. And so among 35 million people in the US, over 7 years, nearly 13% become homebound. Well, here's what's really interesting about this population is 43% fall below the federal poverty line. So they are home dependent on someone else to get out of the house and can't just afford to call an Uber, right? We might think that people with Parkinson's always have someone, but I worked in New York City for 3 years, and I will tell you, I was astonished how many of my folks were living alone in New York City on their own. I had people in a 4th floor walk-up in New York City with Parkinson's disease by themselves. 39% of people who are homebound have 5 or more medical problems. So this was not a Parkinson-specific study, but this was a study of people age 66 and over. At least 2% of people age 66 and over have Parkinson's. And you might argue that people who become homebound might be more likely to be people with Parkinson's than not. So some of these folks, some of this 4.5 million, and 30% have dementia. So this is a really needy population. So I hope to convince you that it's not that people with stages 4 and 5 don't exist. Some of them may be home and have lost follow-up with us, okay? And people ask all the time. So I have the privilege of having an interdisciplinary movement disorders palliative care clinic. And one of the most common questions that we get is, Jori, do people die from Parkinson's? Do people die with Parkinson's? And there's been a lot of debate about this. And so we look at the data that's out there, and it's still a bit hard to say. A lot of people die with Parkinson's and from something else. But some of it depends on the care that they receive. And so here's what we know. This first study I'm going to show you is change in where people with Parkinson's passed. And if we ask most Americans, if we did a show of hands in this room, who would like to pass in a nursing home? Shocking, right? Who would like to pass at home, surrounded by family, plus minus aromatherapy and Enya playing and all of the things, right? But you want to be someplace where you are comfortable. Not that this is something we want to think about, right? But for those who are brave enough to raise your hands, it's 90+% of people in the US say, I don't want to die, but when my time comes, I hope that it's at home, comfortable, surrounded by those who love me. So what happens to people with Parkinson's? Well, between 2003 to 2017, we saw some improvement. 52% of people in 2003 were passing in a nursing home versus 42%. There was an improvement in people passing in a hospital unit from 18% down to 9%. But still, even in 2017, only 32% of people with Parkinson's were passing at home. That's not what people want. That's not consistent with their wishes. And inpatient hospice use has increased, but I want to highlight this number. And happy to talk during the Q&A of sort of hospice and how do we destigmatize, because it is tons of taboo around hospice. But hospice is a benefit of your insurance. It is part of Medicare. Just the same way that depending on which one you've opted into, it covers your meds, you are entitled to this. If a physician thinks that your life expectancy is less than 6 months, how many people with Parkinson's use hospice? What we know is only 4% of people who pass with Parkinson's pass with hospice in place at home. And I will argue till my dying day that is shameful and we should be doing better. We being the medical establishment, we being patients and families speaking up and saying, I deserve this, this is part of what I have, this is available to me, why is this not being used, right? So those are the numbers that exist nationally. Canada does better, and they have slightly more reliable data for some of this. But what do we do, right? We don't want people home alone, okay? So I have the great privilege of working with an amazing team, and really, I went through training to be a researcher. I never thought that I would be a researcher. I thought that I was just going to provide patient care and care for families. And I think that as a researcher, that's actually exactly what I do anyways, because my lab, my team, really focuses on how do we come up with novel ways to reach the people with Parkinson's who've been forgotten, to reach those with advanced Parkinson's and related populations, and improve the quality of life of people living with this today. Okay? My son has attention deficit disorder, and he has trouble with delayed gratification. When it comes to my patients with Parkinson's, I have trouble with delayed gratification. I am not the person who is going to do well in a lab with beakers coming up with a cure. Fear not, there are many people who are working on this. I want something better now for you today. So what do we ask? The questions that I encourage my team to ask are, who are the people who are missing? Who are the people who are supporting them? What are their unique symptoms, barriers, and needs? Why have they fallen through the cracks? And what do we need to do to get them back out and to prevent other people from falling into them? And how do we re-engage people in care, in research, and in advocacy? And I have a very, very simple, I'm blonde. So it is a very simple hypothesis, which is that human connection is required to reach these populations, and human connection can change trajectories of people living with these conditions. So that's going to bring me to talking about interdisciplinary home visits and lessons that we've learned. So that patient that I told you about, Mr. C, he was a patient of mine who I saw on a home visit. Hadn't been seen in forever. How did we get to doing home visits? So I came out of fellowship. I wound up unexpectedly moving to New York City, and I had a wonderful division director who said, you're interested in sort of warm, fuzzy things. I'm losing some of my sweethearts. He had recognized that he wasn't seeing some of his folks. He'd been following them for years and years and years, and then they were missing appointments. Phone calls were being missed. They were in the hospital. Visits were canceled and not rescheduled. And he said, Jori, Go. Take people with you if you need, see if you can go. And so we thought about this, if we think about this in clinical trial terms, when you're testing a new drug to see if it works, the way that Dr. Alskog talked about levodopa. Levodopa on its own doesn't cross the blood-brain barrier. You need that carbidopa to get it there. So there's something called a phase 0 study, which is proof of target engagement. Can we give a person this drug and does it actually go where it's supposed to go? So we started with a phase 0, proof of engagement. Can we cross the office home barrier? Not thinking that this is going to be what's available to everyone out there. This is not a sustainable model of care. I will be the first to tell you that. But the reason for doing this was to convince my colleagues who said, they're not out there, that indeed you are out there. People are out there and are receptive to help. So what we did was very, very simple. We took a social worker, a nurse, and myself or our fellow. I did the simple things. I will tell you of this trio, the doctor's value is the lowest, okay? The secret sauce here is what my nurse and my social worker did, which is going into the home, meeting people all together as this trio. And my nurse would check vital signs, including checking for that blood pressure drop to make sure that often that gets missed, right? Are people standing up and their blood pressure is still down there? She would go and check their medications. So show of hands very quickly. If you go to your doctor for Parkinson's, how many times do they say, are you still taking what you were taking last time? And you say, yes, yes, right? Okay. That has been shown to not be super accurate all the time and to not pick up on errors all the time. So what we did as our real-time medication reconciliation was my wonderful nurse said, take me to your system. And sometimes that was the beautiful tackle box, right? We've all seen it where it's got, 7 compartments for every single day. And it's beautifully organized and that person is maybe type A, right? But sometimes the medication organization system was a giant gallon-sized Ziploc bag into which all of the pill bottles had been emptied. And when the care partner realized, oh, yeah, all right, I think it's about time to take the noon dose, they would just reach in and look for a yellow pill. And I think they're supposed to take a white one at that time too. We had another patient who lived on her own and had delusions and hallucinations and dementia. And her organization system was she had 2 white paper plates. On one, they were identical. On one, there were the bottles of what she's currently taking. And on the one next to it was everything she'd been told to stop. And, she had a pharmacy that was sending her 3-month supply, so the extras were also on that one too. And she was doing this all by herself. We know that medication errors are big in Parkinson's, are common in Parkinson's, and are a cause for emergency room visit and hospitalizations in Parkinson's. So this was not going to the home and bringing my patients deep brain stimulation or the latest, greatest medication. This was making sure that things were going the way they were supposed to go. And then with our patient's permission, we asked if we could walk around their house. And so, for example, I will very likely trip over this at some point because I'm very clumsy, right? But looking at, are there throw rugs that aren't taped down? Because that's a great way for a walker to catch or a cane to catch and someone to fall. With permission, we walked into the kitchen and looked to see, were there burn marks around the stove? Had someone maybe accidentally left the burner on? Was there a sign that someone had accidentally microwaved metal? And then, could we look in your fridge? Would it be okay if we looked in your pantry? Because I had a patient who was seen by one of my colleagues, and in all of the notes, everywhere, non-compliant, right? We're not even supposed to use that word anymore. But non-compliant means I, as the doctor, gave an order, and this is what you're supposed to do, and you did not comply, right? We're supposed to use the term non-adherent, which means we came to an agreement together, and you're just not sticking to it, right? Like less sticky Scotch tape. But this patient was non-compliant everywhere. Why was he non-compliant with taking 1 pill of levodopa 3 times a day, which Dr. Alskog told you should be a dime right? Because his wife, who was working 2 jobs to sustain a studio apartment in Queens that was not much bigger than 2 of these tables combined, his wife was working 2 jobs to afford levodopa, and he had no food in his pantry. So for as much as we worry about protein interacting with levodopa, we need to make sure protein exists first. And so a big intervention for this gentleman was nothing to do with his medications, but was actually making sure that he could get food into his. So really basic stuff, I told you, not a rocket scientist. But this is what our nurse and our social worker were looking at. And our social worker was pulling aside the care partner and saying, what does your support system look like? And when people said, what support system? Trying to figure out what were the resources in the community to build one if they needed it. What's the crisis plan if something happens? And who knows about that plan? And building it if it didn't exist. And so really simple things. I just got to show up and tap and clap and, try not to tug people over, all of this. But then based on what the context was, we made simple recommendations about medications. And more than that, and I love that we've got physical therapy and OT and everyone in the back, connecting people with referrals to services in the community, getting physical therapy in the home, getting occupational and a swallow study into the home, finding, are there resources where there are friendly visitors? Someone can show up and play chess with someone, or read the Bible, or read the Torah, or whatever it is. Can we get some of those resources that exist that maybe we didn't know about before and tap into things in the community? So, what is this giant ugly chart? I have been very, very lucky that many of my mentors have been geriatricians or palliative care doctors or really great internists, besides my mentors who are neurologists. And I told you that a lot of people with Parkinson's don't just get disconnected from us, they get disconnected from their primary care docs. So when we went into the home, and in New York, we did over 480 home visits, we found a lot. We found the depression and the anxiety and the apathy that can go with Parkinson's, and the hallucinations and delusions and the sleep and the constipation. And we actually wound up just publishing in a geriatrics textbook, what are the things you can do for all these symptoms? And I hope you see that while there is a column of pharmacologic interventions, medications we can use, there is arguably an even larger column about all of the other stuff we can do. I challenge you, please come up with a symptom, put it on your card, try and think of something that we don't have something to offer for. We can do something. It may not be a pill, it may not be a surgery, but for almost every symptom of Parkinson's, there are things we can do. And this was what home visits taught me, was there are so many things going on, and a lot of these were low-hanging fruit and easy fixes. We just needed to connect people with the information and the resources. So look at that. There's a whole second page of other things, right? So orthostatic hypotension, that issue with blood pressure dropping, unintentional weight loss. I cannot tell you how many people, because they've heard, and it's true, that protein interacts with levodopa, the response has been, oh, well, then I should just stop eating protein. No, please, no. And I think Dr. Alskog would probably agree. We don't want our patients to stop eating protein, right? We may need to move things around, but you need protein and adequate nutrition to maintain your muscle mass, to do the aerobic exercise that we want you to do to keep this from progressing, right? So we may need to move it around and shift, but please, we don't want people losing weight, because weight loss in Parkinson's is not the good weight loss that the rest of us wish for, right? It's loss of muscle mass, which means if you fall, you're more likely to land on something and have a fracture, have a broken bone. But there are easy, simple things that we can do for all of this. Pain was mentioned. And when I was in fellowship, we were told there was no pain in Parkinson's. I'm not that old. There's been so much recognition in the last 10 years. There are at least 4 types of pain in Parkinson's. There's kind of the arthritic musculoskeletal stiffness pain. There's pain from nerves being crunched. There's pain from dystonia, people sort of crunching in with their muscles. There's central pain that's kind of a deep, achy, hard to describe pain. And we can do things, both medication and non-medication, about all of those. We just have to recognize this is part of it and find the right person to help get treatment for it. So we talked about falls a little bit. There are a number of ways that we can help with falls, and sometimes it's as simple as going through that medication list or the tackle box or the Ziploc bag and going, this medication that you are on maybe used to be useful, but maybe now we've grown out of it. Sometimes people are falling. My patient, Mr. C, was falling because he used to have really bad high blood pressure, and he was on 5 antihypertensives, 5 medications for blood pressure. But Parkinson's was chiming in and lowering blood pressure on its own. So instead of adding on a medicine to bring up the floor and prevent him from falling, we actually just needed to de-prescribe some of his things. So making sure that people are connected to their primary care doc, because sometimes there are medications that we just kind of set it and forget it. But that's not appropriate in Parkinson's. You deserve to be able to review everything and go, is this still right for me? Is this still working for me? And if not, maybe I can get rid of it. No one wants to be taking 27 pills. And then caregiver strain. Can the caregivers, if you consider yourself a caregiver, a care partner, a carer, a champion, whatever term you use, can you raise your hand? Can we applaud you? Because one of the most heartbreaking things for me was when we would go to the home and we would look over and we would, ask all these questions of our people with Parkinson's. And then we would look at our care partners and go, and how are you? And they looked at me and they were like, what do you mean? I was like, how are you? How are you doing? Why? No one's ever asked me that before. Oh, good. Well, let me be the first to start and try to make up for some lost time, right? Because our care partners need so much support. No one was given a book for this ahead of time, right? And we'll get into that a little bit more. So I hope that I've shown you from home visits that there are so many symptoms of Parkinson's. Yes, that's the downside. The upside is, even in these late stages, nearly all of them can be treated, not cured, but treated, made better with medications and non-medication strategies. We've got stuff we can do. Okay, so do we actually have any numbers for this? Is this convincing at all, right? Because if you're a researcher, you have to publish. You have to tell people what you're doing. And there's always going to be a reviewer too who's like, I don't really believe this. This is nice and warm and fuzzy, but this is kind of right? So we started by publishing. We just kind of said, we got to get some of this out there. In 2018, we published our first paper. And this was just a reflection of the first 85 people who we had seen in the New York program. And what's interesting is the median age. So the average age at the first time that we saw people was 79.6 years old. That was older than almost any Parkinson's group that had been published prior to that time. Again, suggesting that these folks are out there. It's just we might not be able to catch people if we're just sitting around in our clinic in our white coat waiting for them to come to us, because that's not where it's convenient for people to be. And in a lot of Parkinson's literature, it is 99% white. And you could say, well, Jori, you did this study in New York. New York is very diverse. True. Our population identified 7% as Black, 7% as Asian, 15.3% as Hispanic or Latinx. And I will tell you that we did the same thing in Chicago, and we had very similar numbers. And people said, well, okay, Jori, but Chicago is very diverse. That's very lovely. So we looked at the clinic population from which we recruited people to home visits. And our clinic population is about 96% white. And our home visit population is about 15% non-white. What does that mean? That means that we know people are reaching, that they're trouble accessing care, But we've convinced ourselves that if people reach the ivory tower, and at Rush, we literally have an ivory tower. The building is called the tower, okay? If people reach the ivory tower, they get to care for their Parkinson's, we think, aha, good, we've got it, we're fine. We are losing people out the other side as they age and as their symptoms get worse. And that's even more true for people of color and for people who are rural dwelling. So this is from New York. We saw people, and I told you about that phase 0, target engagement. Did we see who we wanted to see? Could we cross the home office barrier? And what we saw was at our first visit, 26% were stage 3, 37.7% were stage 4, 32% were stage 5. And I told you that our PT, our OT colleagues are so critical. These are the numbers of how we were referring people. And when I say referring people, I don't mean we gave them a script and said physical therapy would be helpful. I mean, we did it and we made sure it happened. So these are the numbers. 92.7% of our people had a referral made and completed. So I had folks tell me, well, you can't really get people out to the home of these folks. Oh, yes, you can. It takes a little bit of work. It takes figuring out who are the agencies who care about people with Parkinson's and who will make the effort. But oh, yes, you can. And you can make it happen, and they will go. And I mentioned that there were some changes, some interesting findings in terms of white and non-white patients. What we also found in New York was that while we know that Parkinson's is more common in men, when we went out to people who'd been lost to follow-up, who were homebound with Parkinson's, we found more women. And our women were far more likely to be alone. So I think this underscores the value of care partners. We need someone in our life, whether that's a spouse, that's a significant other, whether that's a brother or a sister or an adult child, someone is nudging, is nagging and saying, you gotta go in. We gotta go check on this. We need to go see what's going on. Because if people are alone, they are more likely to be there and not getting the care that they need. So, let's skip over that for the sake of time. So what did we find, right? We went to all this trouble, we went out, we did all these visits, and in a small group of our folks, we followed them. So we followed everyone over time, but we had a cohort who agreed to fill out a bunch of annoying surveys for us. And so we had surveys, 4 surveys over the course of a year of receiving home visits. And what you need to understand is in every other study of Parkinson's, if we look at the natural course of what's going on, whatever the graph looks like, whatever we're plotting, we say Parkinson's goes on over time, function is declining, right? And it's different for everyone. But as function declines, quality of life goes right alongside it. And people had told me that you can't actually change that. This is just inherent. This is dopamine neurons are changing, movement is changing, quality of life is changing, period. I don't know. Because what we found was in a small group, it's very small, that we saw for the course of a year, what we found was that home visits stabilized quality of life, despite the disease progression. And interestingly, I had colleagues who told me, well, Jori, you're not going to see much change. If people are affected enough that they can't even come and see us, there's probably some kind of floor effect. They probably can't be getting worse. Well, Dr. Alskog told you that this is a progressive, slowly progressive, but progressive disease. Just because I put my head in the sand and I can't see you getting worse at home doesn't mean people aren't getting worse at home. And so lo and behold, people were changing at home, but quality of life stayed the same. So this was really encouraging. This made us think maybe we're onto something and maybe we can actually do something that changes this course. Unfortunately, not everyone, I mentioned, has a care partner. And among the care partners who we saw who were still there a year later at the last home visit, their caregiver strain was worsening. So we knew if we were going to keep doing this, we needed to do more for our care partners. So what did we do? I moved to Chicago, which I can't recommend highly enough. Come in the summer, though, because if this is what you're used to, please don't visit us anytime before May. Otherwise, it's not good. But what we knew was we did this program in New York, and people said all kinds of things. They said, Jori, the results that you got are because you were in New York, because you have community resources. People were living in the city. There's all kinds of stuff available. That's not going to translate when people are in the suburbs or rural. They said, well, it was sort of a mixed bag. You had some folks with Parkinson's, some folks with dementia in there, some folks who didn't have dementia. Some people had care partners, some didn't. And also, no one's actually going to be able to do this. Not everyone can go out to the home. And so this was before COVID. We said, okay, let's adjust it. So we built in telemedicine. We were maybe a little bit ahead of the curve pre-COVID. And I sent my nurse and social worker out with an iPad and with a Wi-Fi hotspot. This way, no one needed to remember their Wi-Fi password, okay? And I stayed in my office, and I did all the same things I usually would have done. I did the taps and the claps, but my nurse did the medications. She did walking around the house. Our social worker talked with the care partner about what do you need? What are you receiving? What would be helpful? And then we came together and we came up with a plan. Everyone had to have Parkinson's, plus or minus cognitive changes. And we used a very Parkinson-specific measure to look at change in quality of life over time. And we knew, I mentioned, we knew that we needed to do more for our care partners. So I'll speak a little bit about what we added in there as a bonus. So this is what the study kind of looked like. Was people came in, they had 4 visits over the course of about a year. They came to us from their neurologist, and then at the end, they were supposed to go back to their neurologist. Spoiler alert, many of them are still in my clinic. But we also added in this bonus between the second and third visits to help our care partners. So what did we find? This was a much bigger study. We followed 65 pairs of people with Parkinson's who were homebound and their care partners over the course of a year. They got 4 visits, right? And Parkinson's supposed to get worse over time. So who are these folks? Oops. I don't know what happened to that slide. Well, similar to our New York group, the average age was about 79 at the first visit. Similar to the New York group, our group was less likely to be white than the clinic from which they came. But here's the problem. Oh, there we go. Okay, so here are the numbers. We tried to have a control group. Any good study, you should compare, right? How do we know that what we're doing is actually the thing making the difference? So we tried to compare. And there's always a reviewer, and they say, here's the right way to do your study. And they said, well, clearly, Dr. Fleisher, you should identify people who are at risk of loss to follow-up. You're telling us about this population. Find them, and then half of them you should assign to get nothing. Who's going to sign up for that study? Anyone? Any takers that we say, this is a problem, we're really worried about you? So long, fill out our survey in a year. No one is going to do that. No one should ethically do that. So we said, okay, what is our next best option? So there's the Parkinson's Foundation. They have a huge international registry where if you're seeing a Parkinson's specialist at a center of excellence, you come, you see your doc, you do your taps and claps, right? We adjust your medications, and then you stick around for an extra few minutes and you do a few extra surveys. And if you're in this study, every year they gather the same data. And so we said, well, perfect. Because at the time we started, there were 13,000 people with Parkinson's in this registry who had multiple visits. Cool. Okay, so we said, we're going to give you our list of 65 people, no names. We're just going to give you an ID number and say, here is their age, here is their gender identity, and here is their stage of Parkinson's. It had to only be 3, 4, or 5, okay? And you will give us back, Parkinson's Foundation, as many people who match those same things out of the 13,000. This seems reasonable, right? We gave them an age window and said plus or minus 5 years. So I want to draw your attention. So we had 65 people in our study, 319 Parkinson's controls. And our folks were 78.94 years of age at baseline. The Parkinson's control group, 70. Why are they so different? That's not a good control group. That is a problem. You are not comparing apples to oranges. because when we gave our 65 people, my good friends at the Parkinson's Foundation said, we have bad news. 18% of your people have 0 matches at all, including if we extend it out to 10 years. They are just not represented. And another 26% have just 1 match. Statistically, that doesn't really work out. What does that mean? Are these 13,000 people just disappearing? They're just poof, they're gone? No, they're following up with their doctor at stages 1 and 2 and 2 and 2, and they have a few visits at stage 3, and then they're being lost to follow-up. And so we are drawing that conclusion again that they're not out there, but that's incorrect. So we did the best that we could, and we said, okay, fine, give us anyone who is stage 3 and has at least another visit a year later, and we will compare change over time. So our folks, very few, 21.5% were stage 3 to start with, but the control group is about 85% stage 3. Ours were 63% were in stage 4, 15% in stage 5. So it's a very different group, okay? But what did we find over the course of a year? This is a really busy slide. I'm going to walk you through it. So we used this Parkinson's disease quality of life scale, the PDQ-39. And this looks at total quality of life and has been used in lots and lots of Parkinson's studies. And the higher the score, the worse quality of life. So to start with, our folks who were older, had more advanced Parkinson's, had worse quality of life to start than our control group. However, our control group, like every other Parkinson's study, time goes on, their Parkinson's is getting a little bit worse, their quality of life is getting a little bit worse. But in our home visit folks, their quality of life stabilized. It stayed the same. And when we did all of the statistical tests to try to prove that that wasn't actually happening, it was happening again. So what we saw in New York, we saw again in Chicago, that if we bring comprehensive care to people and meet them where they are, we can stabilize what everyone else has assumed is a foregone conclusion that this is just going to keep getting worse. And I want to draw your attention, there are all these different domains of quality of life: mobility, activities of daily living, social support, cognition, communication, bodily discomfort. And a lot of these things, because of Parkinson's, right, mobility, not surprising, mobility got worse. Activities of daily living got worse. And in the control group, almost every one of these domains gets statistically significantly worse. However, I'm going to draw your attention over here. Bodily discomfort. Remember how I told you that we didn't learn that pain was part of Parkinson's? And we were going in the home and doing really simple things. Like if someone was really in pain, recommending that if their kidneys were safe and their liver was safe, why don't you schedule some Tylenol? Why don't you take it instead of waiting for things to get bad? If your knees are bothering you and that's what prevents you from getting up and moving and doing your exercises, just take some every day ahead of time. Why don't you use some Icy Hot? Why don't you use some Bengay? The easy, low-hanging fruit stuff. Do these simple things and let's see if this works. And lo and behold, the control group has better bodily discomfort to start with and really has no change over the course of a year. But our homebound folks who are older, worse off with their Parkinson's, start off way worse, end up way better with really simple things that we probably have in our closet at home, maybe expired, but we have them at home. Easy things to do. We connected our folks with physical therapy. I don't think that that is unrelated to this, right? So easy things, and they actually made a difference. So we're going to move on from just Parkinson's to a very confusing analogy, okay? Bear with me. This is my chicken, egg, and a confusing umbrella. Okay, so Lewy body dementia. Why are we talking about this at a Parkinson's talk? Because this is a tale of semantic confusion. So you've already learned about Parkinsonism, the slowness, the stiffness, the tremor, the trouble with walking. Yes, these are the movement symptoms. This is why I'm a movement neurologist, right? These are the things. We're going to think of the Parkinsonism as a chicken, okay? Hang with me. But then there's also this component of dementia. So dementia means a progressive decline in a person's thinking or memory that is enough that it's impacting their daily living. And when we think about dementia, when people hear that, right, most of the time we think about Alzheimer's. We think about people repeating themselves in conversation, forgetting maybe a family member, losing the ability to do things. And while Alzheimer's is the #1 most common form of dementia, Lewy body dementia is the second most common form of dementia that is a progressive form of dementia. One of my mentors said, this is the biggest disease you've never heard of. And why? Because this is different. So the changes that people experience are changes in attention and concentration, decision-making. The person who used to be able to multitask now is really struggling with what needs to happen first and then what comes next. The person who was always making the tip or making change at a restaurant is now making mistakes as we get, tax time and all of that. Things are not adding up. They're having trouble with visuospatial processing. So maybe they're getting turned around while they're driving. They go out to go to the store. It's only a couple blocks away and it takes an hour and a half to come back. And they're not quite sure where they were when that happened, right? Or they're walking, they're going to put something away and they're unloading the dishwasher and the forks are winding up, not in the freezer, but the forks are winding up in the drawer beneath where they're supposed to be. Or I had a couple where she was convinced that her husband with Parkinson's, as they approached their 50-year wedding anniversary, had a vendetta against their wedding china. Why? Because he kept doing this. Every time he would set his cup down on the table, the teacup or the plate was right on the edge and kept falling. And she said, I don't understand. For 50 years, he's never said anything about these plates, but suddenly he's destroying them all, right? So people have a hard time with depth perception. And if things are really complex in a field, right, there's a lot of stimulus going on, it can be really hard to find what you want. So someone can go to a restaurant, they can make their way to the bathroom, and then they come and they stand here and they go, I can't figure out where my table is. I do not know how to get back. And they can be very turned around. Those are really specific changes and what we call cognitive fluctuations, which means from one moment to the next, it's like someone is bumping a dimmer switch that controls the level of alertness. So the person who has this can have a conversation about their career from 10 years ago and you never knew anything was different. They are spot on, they are right on top of everything. And 5 minutes later, they had the thought, but the words aren't, right? That they're losing their train of thought. Things become slower and foggier. Sometimes family members will even say, I can tell. They can see the fog drifting in. And there's nothing that someone did to bring that on. There's nothing you can do to snap them out of it. It's just a question of being patient. But that's very different from someone with Alzheimer's. It's moment by moment, kind of day by day, these fluctuations that can happen, and hallucinations. So this group of symptoms, we're going to think about it as the egg, okay? So stick with me. For many, many people, Parkinsonism happens, and then if nothing else gets in the way, if we are living 10, 15, 20 years out, people may develop these symptoms of dementia. And if that happens, if the chicken comes first, followed by the egg, we call that Parkinson's disease dementia. However, not everyone read that book, okay? Because there are some people who develop those cognitive symptoms first, and then later go on to develop a tremor or the stiffness or the slowness. Or everything seems to kind of happen all at once. And if that's the case, we say that that person has dementia with Lewy bodies. However, because we really need to do better with our naming, I did not come up with this. If you have both the chicken and the egg, these are supposed to move over there, but they're not doing it. If you have either Parkinson's disease dementia or dementia with Lewy bodies, whatever order they came in, we say that that is Lewy body dementia. So I have a lot of people, a lot of family members that will come to me and say, my loved one was diagnosed with Parkinson's, and now I'm being told that the diagnosis was wrong. Now I'm being told that they have Lewy body dementia. Not a separate diagnosis. It really can be part of it, the same way that we don't say, well, I was told my loved one had Parkinson's and now I'm told they have constipation. It's part of it, right? And not everyone gets it, okay? People familiar with the Cheesecake Factory? Yes? Yes, okay. Has anyone here ordered every single thing off of the Cheesecake Factory menu? It's impossible, and we would be concerned, right? But no one gets every single symptom, right? Just like no one gets every single thing, but when these happen together, we call that Lewy body dementia. And I talked about this a little bit, but what are the differences between Lewy body and Alzheimer's? So that attention, judgment, visual perception problems are a Lewy body issue versus memory loss, repetitive questions. Hallucinations are very common in Lewy body, especially repetitive visual hallucinations. Not so much in Alzheimer's. Misidentifying familiar people, something we call Capgras syndrome. This is more common than we recognize, and if we ask about it, we will find it. This is one of the things that I teach my fellows all the time, is the person with Lewy body dementia who keeps saying, I want to go home, I want to go home, I want to go home. And family says, but they are home. Do they mean like their childhood home? It doesn't exist anymore. Do they mean a vacation home? There's something that goes on where the visual perception, I've already told you about the wedding china, right? Things look a little bit different, kind of like things in the rearview mirror are not quite as they appear. There's something that's telling that person, even though everything about this room looks right, even though that looks like my bed and that looks like my TV and that looks like my picture frames, I know it's not quite right. Something feels off. And that can happen with places, but that can also happen with people. So the number of times that I have care partners tell me, I don't understand, but she seems suspicious of me. Why is she suspicious? Why is she asking what my name is when I know she knows my name? Or they're saying, are you the real Judy or are you the other Judy? How many Judys are there, right? And it's because people are having this Capgras syndrome where something just looks a little off. I don't know if anyone has ever seen in Times Square, the characters when people wear like a Mickey Mouse thing and it's just not quite right. Like, you know what they're getting at, but it's a little off and disturbing. This is what I think about when people are experiencing Capgras syndrome. We know that people have REM sleep behavior disorder, and we know that they have trouble with autonomic system regulation. So we talked about the blood pressure issue. We talked about constipation. It's a huge problem. I had no idea going into neurology, I would spend so much of my day talking about constipation. And then I go home and have small children, so I spend the rest of it talking about the same thing. But urinary issues as well, and trouble with temperature regulation, right? The person who was always comfortable before now needs a sweater all the time. Or they're sweating all the time. What is up with that? And that can be part of this too. So what I want you to know is, just like all of those other symptoms that we talked about, if this is something that you are noticing now or in the future for yourself or a loved one, there are things that we can do. For far too long, we have thought, well, there are some medicines out there, they don't really do anything. There's increasing evidence that the medicines that were developed for people with Alzheimer's and don't really do very much actually are more helpful for people with Parkinson's and Lewy body. And so we use them. They can actually, even though they're there just for some of the cognition, for the thinking, some of them actually help keep the lid on hallucinations, right? So there are things that we can do. And around 2000, this is the poor professor who was like, what do I have to offer? What's coming down the pike when the patient says, are there clinical trials for me? No, nothing. Fast forward, there are over 40 drugs in the pipeline for people with Parkinson's, dementia, Parkinson's and hallucinations, Parkinson's psychosis, Lewy body dementia. However we put an umbrella over this, people are starting to care and wake up and study and come up with better treatments. So we have things today, and we will have more things tomorrow. Okay. This sounds like a terrible slide, but I promise I'm not going to end like this. So I've told you about hospitalizations and nursing homes, right? Why do people with Parkinson's wind up in the hospital? There's some very common things: falls, urinary tract infections, dehydration, and some of those neuropsychiatric issues, the hallucinations, delusions, depression, anxiety, and caregiver strain. Does that surprise anyone? When we compare, they have done studies where we can sort of pound for pound statistically say, okay, if you had two identical people with Parkinson's and they both have the exact same symptoms, which never happens, okay? But let's say we did, but one has a care partner who is at the end of their rope, and the other has a care partner who's maybe connected to a support group, connected to, they have family, they've got someone backing them up, they get it. The person whose care partner is at the end of their rope is far more likely to wind up in the hospital with a problem, to wind up in the emergency room, in a nursing facility, and they're more likely to pass sooner than someone who has a care partner who feels supported. And once someone with Parkinson's is in the hospital, they have longer lengths of stay in the hospital, all kinds of things happen. So we really want to keep people out of the hospital. And if we look at these things, the hypothesis is many episodes of ER visits and hospitalizations seem like they should be preventable, or that we could catch some of these things early and manage them at home if we could recognize them. But doing so requires an educated, engaged, and observant care partner. So, sorry. All right, what do we know about care partners? This is very end. Have people seen Encanto? Yes, I hope. Okay. If you have not, I strongly recommend it. Louisa is the big sister, for people who don't know. She is carrying the weight of the world on her shoulders. I feel like our Parkinson's care partners have big Louisa energy, okay? So what we know is that about 83% of people living in the community with Parkinson's or Lewy body are depending on unpaid caregiving from a family member. If we paid for that, that would be about $232 billion with a B, $billion worth of caregiving every year. People lose their income caring for a loved one with Parkinson's, and when we compare Parkinson's care partners to Alzheimer's care partners, who've been way more studied, what we find is that Parkinson's and Lewy body care partners have higher caregiver strain, have higher caregiver burden, have higher rates of their own depression, have higher rates of sleeping issues, have higher rates of back pain than other care partners. And I had someone write in, one reviewer two, again, said, well, why? Why do you think that is? Why should they be any different? And I get to work with Lewy body care partners and Parkinson's care partners on my research team. And they said, oh, we have words for reviewer two. The words only had 4 letters, but they had words. And we think that it is because there is this combined change in motor and thinking and neuropsychiatric and non-motor domains, plus things are really unpredictable. And so from one day to the next, it's really hard to know, is it going to be a good day? Is it going to be a bad day? Is it going to be a good moment? Can we get to the party? Can we get to therapy? Can we get out and do the things? So I'm going to skip over that for time. We talked about caregiver strain being a predictor. So what have we done so far? Whole lot of nothing. There are very few studies that have focused on Parkinson's or Lewy body care partners, and so far nothing had been shown to be effective. And if we look at dementia and caregiver interventions for dementia, there are a few that are out there that have been helpful, but they're usually really expensive things where there's a nurse calling you like 3 times a week, and then they're sending you to a support group and you're doing these things, and who has time for that, right? And no one has funding to support something like that. So I mentioned that I have this clinic, and the most heartbreaking thing is when I have care partners come to me and say, okay, Jori, I think we're ready to finally sign up for hospice, because that means someone will come help, right? And that is unfortunately not what hospice means, because insurance doesn't cover paid caregiving. Paid caregiving is not part of Medicare. It's not part of hospice. It's very expensive. Depending on the area of the country you live, it could be $30 an hour or much more. Very few people have that set aside. Who is planning for that? Caregivers are in really high demand and low supply. There's high turnover and burnout. And most don't know anything about Parkinson's. So this sounds terrible, doom and gloom. I promise that is not what I'm leaving you with. But this is not a sustainable option for most, right? So where's the cavalry? The cavalry is not coming, except we saw in our home visits, I told you that home visits were not going to be enough to help our care partners. So we needed to do something else. So there's this idea floating around of peer mentoring. And some of this is what happens in support groups, talking with someone who's walked the same journey and gets it, right? This is a very simple idea. People had looked at this in Alzheimer's. And about 10, 15 years ago, the data coming out was, it's hard to say by the numbers that this really helps. But when you ask people to tell you about their experience, talking with someone who gets it, they will go on for pages and tell you how important this was. So we looked at this and said, okay, maybe this, has anyone tried this in Parkinson's? No, not yet. But where this has been shown to be effective is in all of these other groups, and I won't read through them all, but I think most shocking to me, right? To imagine someone saying, I've been through a journey for myself or for a loved one, and I'm going to willingly put myself back into that place if I'm not still in it, so that I can make this better for someone else. I cannot imagine, as a parent of 2 small kids, but there is a study that looked at bereaved parents who had lost their child to cancer, and they signed up to mentor other parents who are going through that process to make the journey better for someone else than it had been for them. If they could do that, right, then this seems like a pretty powerful thing. So we said, let's give it a shot. And so we knew that home visits weren't going to be enough. So moving the home visit study from New York to Chicago, we had our people, and between home visit 2 and 3, we said to the care partner member of the pair, hey, we're going to give you a phone number. Someone's going to give you a call. They've been on this journey. Might not have looked exactly the same, but they're a safe person. We vetted them. We trained them for a couple of hours. Just talk to them. We'd like you to talk once a week, but we didn't tell them how long to talk. We gave them a little tiny guidebook, just kind of the stuff I'd hand out in clinic, little tip sheets. And lo and behold, over the course of a year, we found that even though our caregivers had higher strain to start with, at the end of the year, their strain hadn't changed. But in the control group, caregiver strain got worse. So this time in New York, we saw this caregiver strain was getting worse. We added in the peer mentoring, and now caregiver strain didn't change, which was really promising to us. And they actually did it. So people talked about 11 times in 16 weeks. We know life is busy. We didn't tell them how long to talk. They talked for 30 minutes. These are folks who are actively caregiving, right? And they made that time because it was valuable to them. So we said, okay, COVID was just starting to hit. We can't do our home visits anymore. But this peer mentoring thing, maybe this has legs. Could we do this, and could we do this virtually? So some background on me is I was raised by a very tight-knit family in Cleveland. I grew up thinking everyone had an aunt in a wheelchair who was nonverbal, who was part of everything. It took me until probably middle school before I realized not everyone had an Aunt Kim, and an Aunt Kim who was raised by parents who in the 50s told them that kids with really severe neurologic disorders, there was nothing that they could do, and it was probably just better to put her in a home and let her die. And my grandparents, just like our Lewy body care partners, they had words, and they said, we're not doing that, and they kept Kim at home, and they took care of her. And my grandmother taught me at age 4 the word perseverance. I don't know why, but it's this core memory of learning the word persevere, which the dictionary says is to continue in a course of action, even in the face of difficulty or with little or no prospect of success. Now, if you're making a grant and you want to get their attention, you're supposed to have a very catchy acronym. So if you squint and you put together these letters, peer mentor support and caregiver education in Lewy body dementia, you can sort of get persevere out of that. So this was our pilot of learning to persevere. And what we did was we took this idea of peer mentoring. We said, can we make this entirely virtual because COVID? And instead of just this being in Chicago, can we make this national? So we partnered with friends at Lewy Body Dementia Association and the Parkinson's Foundation and said, would you share this with people? Do you believe in this enough that you would tell people about this? We took that little 30-page book that we had created and we did focus groups of care partners and said, too much, too little, are there things that you feel like it would be helpful to know? and they had feedback. So we went from a 30-page little guidebook to an almost 400-page book that you could bench press and see results from, okay? Because there was so much that people said, Jori, like I can go look for some of this online, but I don't know what to trust and I don't have the time. And Uncle Google knows very little about Parkinson's or Lewy body. So we created this curriculum, we partnered up, we trained 36 new mentors. And even though in some of the other peer mentoring studies, they said it doesn't really matter who you match with who, if they've got the same experience with a condition, it's all probably the same. I hope you are thinking to yourself, but it's not the same. It's not the same, right? People have preferences. This is why there are dating apps, okay? So we're not Tinder. We came up with very simple algorithms and asked people, how important is it to you to be matched to someone who's similar in age, who's in the same time zone to make calls easier, who shares the same role? So are you a spousal care partner or are you an adult child care partner? And then we tried to match people up based on what they wanted. And what we found, number one, I told you we asked people to give us what information they wanted, all of it. So anything in blue was completely new that had not been in the original book. Anything in black was heavily expanded. And they said, Jori, it's not just symptoms. We can read about symptoms. We might not trust what we're reading, but we can read about symptoms. But I feel so angry sometimes. And I feel like I'm the only one who feels angry. And I don't feel like I can say that in a support group. I feel really guilty. You know, the physical therapist said it should be 4 times a week, but I'm still working and I can't get my loved one there 4 times a week. So is 2 times a week okay? Or am I harming someone? I feel so much guilt. How do I plan for the future? So there wasn't anything good out there. So we created it with Lewy body and Parkinson's care partners. We matched our people up. We trained our mentors. And we supported our mentors because we knew that this could be really emotional work to talk with someone who's going through it. And so we set up basically support groups for the supporters. So mentoring calls for our mentors. And what did we find? Despite active caregiving demands, a lot of our mentors were still actively caregiving for their loved ones. They prioritized learning to persevere. So we had 30 pairs. They completed over 400 calls over the course of 16 weeks, 15 calls over 16 weeks this time. And they talked even longer this time than in the first study. And again, we didn't tell them because I don't presume to know what your life looks like and what your timing looks like. We hope this is helpful. And 100% found it useful. 100% said that they recommend it to other care partners. And what I think is most compelling, and I'll show you, we've got great numbers. People learned, they improved their attitudes and their confidence and their skills. That's wonderful. But I told you that our current healthcare system is broken. The cavalry isn't coming. What we asked people was, if you were a mentor in this, and we asked you to do this again, would you do it? And 90% of the mentors said yes. And we asked the mentees who were earlier in their journey, if you had the option and you could go through it again with a different mentor, be a mentee a second time, or be a mentor. 40% said, I feel like I have more that I could learn. I'd like to be a mentee again. 10% were like, I'm good. I'm good right now. But 50% of our mentees said, call me in, coach. I want to make this better for the people coming after me. And I want to become a mentor to other folks. So we've been waiting for the cavalry to come. And it turns out the cavalry has been around us the whole time because you all have so much lived wisdom and so much benefit can be had by sharing it. So this was exciting enough. We did lots more work, lots more focus groups to get it even better. And then even though, and this was before recent NIH changes, previously, NIH, the National Institutes of Health, was not huge on funding a lot of caregiver research and was not huge on funding a lot of Lewy body research. They were really not huge on funding Lewy body or Parkinson's caregiver research. They funded it. And so we actually have ongoing now persevere. We learned to persevere and now we're persevering. And so this is actually an ongoing open randomized controlled trial across all 50 states and US territories. So if you have Parkinson's or Lewy body friends in Puerto Rico or Guam, go visit them. and then tell them that we have support for them too. We are enrolling folks who are current care partners or past care partners to serve as mentors. And we are enrolling family care partners who are actively caring for a loved one now, as long as their person with Parkinson's has some cognitive changes. So if that is you, if that is someone you know, please feel free to share this. Participation is about 9 months for people sort of early on in the condition, and everyone gets something. So I told you that in home visits, they said you should randomize people and half should get bupkis, nothing. And we said, no, thank you, that's not how we're doing this. So even people who are randomized in this study to the control group get 12 weeks of educational resources that we have put together and trusted and validated and make sure that they're legit and you can believe in them. So this is ongoing, and that's the link if people have interest. All of it is online or by phone. So all of it is on your own time and across all of the time zones with lots more information online. Where are we? Ooh, I don't know what happened to those numbers on the bottom. That is funny. But the response so far has been incredible. Again, because the cavalry has been all around us this whole time. We opened enrollment in May of 2024, and we actually already hit the 120 peer mentors who we thought we needed. We just opened enrollment and expanded it a little bit further to make sure that we have all of the people that we need. However, we are trying to reach 500 care partners whose loved ones are in the first couple of years of having any cognitive changes. We are halfway there. If you know people, send them our way. We would be so appreciative. We hope that it's helpful. And we know that most studies, care partners tend to be represented as women. So we are specifically trying to reach male care partners who live in rural areas. We've partnered with the Veterans Association to reach some of our rural vets, and also care partners of color. So this was taken from last week. I want to draw your attention. California is representing, okay? I will tell you though, when I looked, I didn't see any Santa Barbara folks yet, but that's yet. So this is where we are so far. And this is how people are finding out about us. So the most important thing has been, for the most part, care partners telling other care partners, telling support groups. My social worker and I will zoom into any support group and give a talk about Parkinson's or Lewy body or all kinds of stuff. We want to get the word out. We want people to know that there is education and hope out there, and for you to recognize how much expertise you all have. So with that, I put in so many logos, I'm sorry. So that is information. I have some flyers if people want flyers. I am too young to retire and felt that I was too old for TikTok. And one of our 79-year-old care partners went, Jori, there are Parkinson's care partners on TikTok. You need to go on TikTok. So it took a year, basically, to get approval from our institution to go on TikTok. I am not dancing, but we just launched a TikTok and an Instagram that will be like life tips and life hacks and easy, simple things. How do you get in and out of a car with Parkinson's or Lewy body? So with that, I hope that you have the following conclusions or takeaways. That individuals with late stage or advanced Parkinson's are understudied, underrepresented in research, amenable to clinical care and research, and benefit from comprehensive care that can stabilize and even improve symptoms and quality of life. And so the takeaway one is no one is past the point of help in Parkinson's, and the medications don't stop working. Number two, Lewy body dementia is an umbrella term covering Parkinson's dementia and dementia with Lewy bodies. The terms are stupid and confusing, okay? But recognizing the cognitive changes leads to better management today and in the future, and there is hope on the horizon. Number three, there are identifiable and potentially preventable or manageable causes of hospitalization, and any sudden change in your Parkinson's symptoms, okay? The dopamine cells are not unionized, okay? So they did not just poop out, right? Any sudden change isn't usually Parkinson's. Think infection, dehydration, take action. Family caregivers have higher strain and burden than caregivers in other conditions. Caregiver strain is common, it is real, it is a risk factor for hospitalizations and nursing home placement, but it is potentially modifiable with peer mentor-led educational interventions and support. And despite the high strain and burden, caregivers will willingly share invaluable lived experience and mentor newer caregivers on this journey who then improve their own knowledge and attitudes. So unless or until our healthcare system changes, one of the biggest sources of caregiver support and wisdom is connecting with others who are on this journey. Please never underestimate how much you know, how much you have learned, and how much what you've learned can help someone next to you. Word of mouth referrals from one caregiver to another have actually been the big driver for recruitment. So the takeaway is you are not alone. You know more than you think you do, and you can make this journey better for others who follow. So with that, I want to acknowledge my amazing teams. I want to thank PASB again. I want to thank my kids who always encourage me to look at the future and what do we make better tomorrow. And those are my grandparents. I mentioned that they took care of my Aunt Kim, who had severe neurologic illness and they refused to give up on her. And I went into movement disorders because it was the only field of neurology that hadn't really affected my family. And then, after I was a movement disorders neurologist, my grandpa developed DLB, and my grandmother, Ro, developed Parkinson's. So I have seen this in clinic every day. I have seen this from a research perspective. I see it in the evidence, but I see it also as a family member. So I know how much hope we need. And I'm telling you, with all of those other hats on, there is hope on the horizon, and there is so, so much that we can do. So thank you so much for the opportunity. I'm sorry to run long. Thank you all.